me a moment. Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clirnet, serving as the allocated session assistant to ensure a seamless experience. Clirnet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clirnet serves as a digital partner for this event hosted by National Medicos Organization, and the focus of today's session is Physiology Clinical Case Discussion Day 4. Now, I would like to invite Dr. Ajay sir to proceed. Over to you, sir.
Thank you, Rimpa. Good evening, everyone, and a very happy Krishna Janmashtami to everyone. I am Ajay on behalf of JSL Medical College Rajahmundry and the National Medicos Organization. I extend a warm welcome to you all for day 4 of our 4-day physiology clinical cases discussion series. Today, we will be focusing on the central nervous system. We are truly privileged to have with us our speaker, Dr. Perninkal Srinivas Rao, sir, Professor, Department of Physiology, GSL Medical College, Rajahmundry, and also President, Arogya Bharati, Andhra Pradesh. Today, we are honored to introduce Dr. Ravi Shankar, sir, Associate Professor, Department of Anesthesia, at Sri Venkateshwara Medical College, Tirupati, and the President of National Medicos Organization, Andhra Pradesh. Sir has been working tirelessly to bring the spirit of nationality, values, and service into the medical fraternity. Today, Sir will be sharing his insights about NMO with us. And we will begin the session with the Dhanvantari Vandana. Thank you.
आदिदेवं सुरैर्वन्मादपद्मम् लोके जरारुभयमृत्युनाशम् धातारमीशं विविधौषधीनाम्. Sir, are you there?
You are asking me, Ajay?
No, sir. Ravi, sir.
Okay. Till he comes, I am very happy to see this. Natvaham kamaye rajyam, nasvargam napunar bhavam. Kamaye dukkataptanam, praninam artinasenam. This is a story from Bhagavatam, where a king, after conquering the whole world, suddenly feels very sad that people are falling ill and falling sick. So he starts praying to Lord Krishna. Because today is Krishna Ashtami, I would like to tell this story. He prays to Lord Krishna, and Lord Krishna appears in front of him and asks him to choose whatever he wants. He will say, Natvaham kamaye rajam, I don't want kingdom. Na swargam, I don't want heaven. Na punarbhavam, I don't want to be born again. Kamaye dukkataptanam, I want all my people not to have suffering. Praninam arthinashanam, all the living beings, distress should be reduced. So this was the boon he asked Lord Krishna when the Lord appeared before him. So I'm very happy to see this shloka also here. It is from Bhagavatam. Okay. Till he comes. Today is the last day of my program for this cycle. I'm very sorry that I could not complete all the clinical cases because you have quite a few. So some important chapters are blood, digestive system, then respiratory system. You have quite a few cases coming from those chapters also. Today we'll be completing the nervous system, both central as well as peripheral nervous system.
So we can start in 2 minutes.
Okay. Able to continue all
Sir,
the
1 minute. Sir, you can make the screen full
okay.
screen view, sir. And also, I request the participants not to write anything on the slides. You can use the chat box for making this session interactive. Thank you. Thank you, sir.
Okay. So today I'll be talking about some of the important cases that you will be getting in your exam, and I have limited myself to the cases also because CNS we have to give a little more concept oriented. Uh, so the first case is a 64-year-old man presents with a 2-year history of progressive slowness of movement and tremor. So this is important. Progressive slowness of movement. So there is a decrease in the movement and there is tremor. Tremor is an involuntary movement of the fingers or any part of the body. That is called a tremor. So there is a progressive slowness of movement. That means he will be walking slowly, but his fingers are having a tremor. His wife reports that his handwriting has become smaller and he has difficulty starting to walk. This is important. Starting to walk, he is having a difficulty. Not only walking is progressively slow, but he is having difficulty starting to walk. That means initiation of the movement is becoming difficult. On examination, you observe a resting tremor. So I think you know there are two types of tremor. One is a resting tremor and the other one is called an intentional tremor. Intention tremor means when you are about to do some work, suppose I am going to pick up something, then there is a tremor. But when it is at rest, there will not be much of a tremor. Whereas here he is having a resting tremor in both the hands, rigidity in the upper arms. So rigidity in the upper arms and a stooped posture. So I think you know what is rigidity and what is spasticity. Rigidity and spasticity are in different diseases. You have a spastic limb when you have an upper motor neuron lesion. But rigidity is seen when both the muscles are involved, both the group of muscles are involved. So in this particular case, there are two types of rigidity. One is called a lead pipe rigidity. It is something like trying to bend an aluminum pipe. Imagine you are trying to bend an aluminum pipe. It will be bending slowly, isn't it? That is called a lead pipe rigidity. Second one is called a cogwheel rigidity. That means like a clock. Tuck, 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 tuck. It will be going slowly. So that is a cogwheel rigidity and a stooped posture. So here the posture is stooped means he is falling in forward. I will be showing that in the next slide. His facial expression is reduced and speech is soft and monotonous. So he's having a fixed face. And that means his expression muscles are all not moving properly. And speech is soft and monotonous. That means he will not be having any expressions in his voice. He will be talking in a same tone. That is called monotonous. There is no history of cerebral stroke, head trauma, or use of dopamine blocking drugs. MRI of the brain shows mild generalized atrophy but no focal lesions. So MRI is almost normal. There is only a mild generalized atrophy. So here, what are the things you have to remember? 2-year history of progressive slowness of movement and tremor. Handwriting has become smaller. It's called agraphia. Difficulty in starting to walk. Resting tremor is present. Rigidity in the upper arms. Stooped posture. Yeah. Anyone would like to make a guess of what this could be? This is one of the common questions they have given in CNS. Anyone? Vijay? Jonathan? Anyone can make a guess? Very good. So this is Parkinson's disease. So you can see here, the main symptoms and signs will be tremors. And how are those tremors? Resting tremors. Then muscle stiffness, that is rigidity, slow movement, and he will be having problems with his bend, his balance. See, you can see this person. This person is having a stooped posture. Stooped posture is when he's moving, what will happen is his center of gravity will be forward. So the next leg also he'll be putting in front. So he'll be walking in a shuffling gait. This type of gait is called festinant gait. What is it called? Festinant gait. That means he'll be trying to catch his own center of gravity. He'll be bent like that. His legs are stiff. So he'll be having a difficulty in starting the movement. So he'll be putting one leg forward and he'll be almost falling. He'll put the other leg forward. So like that, he'll be going. That is called a shuffling gait or a festinant gait. So now this is a lesion of the basal ganglia. So which part of the base? See, many of you are telling only basal ganglia in the exam. You should be telling which part of the basal ganglia also. Remember that. So it is the substantia nigra. So this is the substantia nigra. So you can see here, caudate nucleus, putamen, thalamus, substantia nigra, everything is there. Globus pallidus, externus, internus, and that is the internal capsule in between. You can see here that this is the internal capsule, the anterior limb, posterior limb, and this is the genu. So this is the basal ganglia. So what is the function of the basal ganglia? It helps in the initiation of the movement. So that is why these people, when there is a lesion, will be having a difficulty in starting any movement. After the movement is started, it is only a rigid movement, but otherwise they'll be having a difficulty in starting the movement. So which clinical features in this case support the diagnosis? Resting tremor, I told you, more prominent on one side here. Whereas intention tremor is common in cerebellar lesions. You remember that. Resting tremor is common in Parkinson's. Intentional tremors are common in cerebellar disease. Bradykinesia, that means slowness of movement. Because of the stiffness, he'll be having bradykinesia. Rigidity. So I told two types of rigidity. One was cogwheel rigidity and the other one was called lead pipe rigidity. Stooped posture, that means he will be bent forward like I showed you in the picture. Reduced facial expression, that is called hypomimia. So if this word is new, please write it down. Hypomimia, reduced facial expression, and soft monotonous speech. This monotonous speech is called hypophonia. So this soft monotonous speech is called hypophonia, and reduced facial expression is called hypomimia. For you to easily remember, suppose I crack a joke, everyone will start laughing, isn't it? Whereas this fellow will not be able to express his happiness. అంటే లోపల లోపల హ్యాపీగా ఉంటాడు అనమాట, బయట ఏం కనపడదు. His face will be expressionless, but it is not that he is not enjoying the joke. He is enjoying the joke, but his face will be expressionless. In that movie, there is one lady, no, like that. So that is one feature of basal ganglia disease. So resting tremor, more common on one side. Bradykinesia, slowness of movement. Rigidity, two types of rigidity. Stooped posture, reduced facial expression, that is hypomimia, and soft monotonous speech, that is hypophonia. So all this suggests that it could be a basal ganglia disease. What is the pathophysiological basis of this condition? Degeneration of the dopaminergic neurons. This you have to write. It has to be written that it is the degeneration of the dopaminergic neurons. Don't write it is a degeneration of the substantia nigra. Don't write like that. You have to write degeneration of the dopaminergic neurons in the substantia nigra pars compacta. I think you all know substantia nigra has two parts. One is called the pars compacta, one is called the pars reticulata. So here it is the dopaminergic neurons in the substantia nigra pars compacta, leading to a decreased dopamine in the nigrostriatal pathway. So the neurotransmitter is dopamine, which is reduced in the substantia nigra pars compacta. What is the first line of pharmacological treatment for this patient? So some of you are writing only levodopa, but if you want to get good marks, you have to write levodopa with carbidopa. Like that you write levodopa with carbidopa. This is a small secret I am telling you, because levodopa, if you write, it is correct. It's not that it is wrong, because with a levodopa directly acts on the brain. Peripheral action is less. So levodopa with a peripheral decarboxylase inhibitor such as carbidopa, that is better, is preferred in older patients with functional impairment. Why? Levodopa remains the single most potent drug for improving bradykinesia and rigidity, which are often the most disabling symptoms in an older patient. Reduced peripheral side effects with decarboxylase inhibitor. So levodopa will again come into the bloodstream, and when dopamine increases in the bloodstream, it has so many side effects. So that side effect is not present if carbidopa is also given along with levodopa. So you can write levodopa is the first line of pharmacological treatment with carbidopa. Why is carbidopa added? The side effects of levodopa of dopamine will not be seen. Carbidopa prevents peripheral conversion of levodopa to dopamine, reducing nausea, vomiting, orthostatic hypotension. See, orthostatic hypotension means the hypotension comes when the patient stands up suddenly. See, first of all, he is not having a balance. Understand? The patient is not having a balance. And suppose he starts falling because of orthostatic hypotension, that is more troublesome. That's why carbidopa is always given along with levodopa. Okay. So that is the first line of pharmacological treatment. Yeah. Now, this is important. Explain how degeneration of the dopaminergic neurons in the substantia nigra leads to the observed combination of tremor, rigidity, bradykinesia, referencing basal ganglia circuitry. I think all of you know there are two types of pathway in the basal ganglia. One is called the direct pathway, one is called the indirect pathway. Direct pathway will be having D1 receptors, indirect pathway will be having D2 receptors. One will increase movements, one will reduce movements. So for you to easily remember II, that means indirect pathway inhibits movement. So this is the easy way to remember. Indirect pathway inhibits movement. Direct pathway facilitates movement. So the substantia nigra pars compacta sends dopaminergic projections to the striatum. Corpus striatum means caudate nucleus and the putamen nucleus. So dopamine has two pathways, direct pathway, indirect pathway. As I told you, direct pathway facilitates movement by exciting the cortical motor areas. Indirect pathway inhibits the movement. Dopamine activates the direct and indirect path, inhibits the indirect pathway. So overall effect is movement initiation and smooth execution. So this is in a normal person. That means they will be balancing each other. The direct pathway and the indirect pathway will be balancing each other. So there is no increase or decrease of the movement. It is smooth. So this is the thing you can look at this cerebral cortex, putamen, from there D1, D2, GABA. GABA is the inhibitory, subthalamic nucleus. All this you can go through that in your leisure. I'll be sending the PPT. So the thing that you have to remember is in direct pathway, it is facilitatory. Indirect pathway is inhibitory. This you strongly remember. D1 and D2 receptors. What happens in Parkinson's disease? Degeneration of the dopaminergic neurons in the substantia nigra compacta. There is a decrease of dopamine in the striatum. Without dopamine, what will happen? Direct pathway is underactive. So, less amount of facilitation of movement. I told you, direct pathway is always facilitates the movement. So, it becomes less facilitative. Indirect pathway becomes overactive. That means more inhibition of movement. So there is less facilitation, there is more inhibition. So the net result will be thalamus is excessively inhibited. There is a reduced excitatory input to motor cortex. So the main function of the basal ganglia, that is initiation of movement, will not be there because of this inhibition. That is why you have rigidity. So because of this rigidity, there will not be any facial expression. So the face of the patient, because of the muscles rigidity, it will be expressionless, and he'll be having a festinant gait. He'll be losing his balance, and he'll be having unintentional tremors. That means resting tremors. They will be having resting tremors. So these are the common things which are seen in Parkinson's disease. You have to know what is the treatment. Don't write only levodopa, write levodopa with carbidopa. I think you understand why it is important. Carbidopa will not allow the dopamine to have its side effects. Levodopa has its action directly on the brain, on the dopamine. So this is the symptom, bradykinesia, slowness of movement. That is because decreased activation of the direct pathway, increased activity of the indirect pathway. So difficulty in initiating the voluntary movement. Rigidity, lead pipe or cogwheel, increased tonic activity of the alpha motor neurons due to excessive inhibitory outflow from the basal ganglia, altering muscle tone. I think all of you know that the tone of the muscle is having two types of stimulation. One is called the inhibitory and one is called the stimulatory. So it is both stimulated as well as inhibited. So here what will happen? There is an increase in the tonic activity of the alpha motor neurons due to excessive inhibitory outflow from the basal ganglia. So that is why the muscle tone becomes like a rigid. So two types of rigidity, lead pipe or cogwheel. Resting tremor, this is not explained properly why you have a resting tremor. But most common thing which they are proposing is it is likely due to abnormal oscillatory activity in the basal ganglia. So the thalamus cortical loop is there and the cerebellar pathways are there. Both these places, there is an abnormal oscillatory activity. Oscillatory activity means it is an activity which happens in milliseconds. So it happens in milliseconds, and because of the oscillation, you'll be having these tremors. Then postural instability. I told you they'll be falling, they'll be losing their balance. Postural instability, loss of dopaminergic modulation of brainstem locomotor regions, and integration with the proprioceptive inputs. So all this is lost because of the lack of dopamine. So I have put it in a table form for you to easily refer when you get the PDF. What you have to remember here is it is the substantia nigra compacta, where you have dopaminergic fibers. You have D1 and D2 receptors. The D1 receptors are stimulatory, the D2 receptors are inhibitory, and direct pathway will be having the D1 receptors, indirect pathway will be having the D2 receptors. The direct pathway is facilitatory, the indirect pathway is inhibitory. So normally there is a balance between these two, and that is why the movement is smooth. But when the dopaminergic fibers are disintegrating or they are not functioning properly and there is a decrease in the dopamine, then what will happen? There will be an increase in the inhibition because the facilitation will not be happening. More of inhibition will be happening. That you can make out from the direct and indirect pathway, how GABA is released, how glutamate is released, all that. You be thorough with that diagram because this can be given even without a case. It can be given directly also. See, some of you have asked me how to prepare for reasoning questions. See, every question which I am telling now is a reasoning question. So there is no separate way where you can prepare a reasoning question. If you ask why, if you know the concept, that is a reasoning question. Understood? So why there is a problem with initiation of movement? That is a reasoning question. So there is nothing like preparing separately for a reasoning question. If you understand the concept, that is the answer to the reasoning question. So don't by heart concepts. Understand the concept. The idea of giving reasoning question is whether you have understood it or not properly. Okay. Now, a second case. A 58-year-old man suddenly develops weakness of the right side of the body and slurring of speech while at work. Suddenly he developed this. It is not slowly progressive like the previous one. Here it is sudden. He is brought to the hospital within 1 hour. On examination, he has complete paralysis of the right upper and lower limbs. So, one-sided paralysis, that is called both right and upper and lower limb. So, it is called hemiplegia. Understood? If both the lower limbs means it is called paraplegia. Okay. So, here it is hemiplegia. That means the right upper and lower limbs. Loss of sensation on the same side and deviation of the tongue to the left on protrusion. So, right-sided upper and lower limb paralysis and deviation of the tongue to the left on protrusion. That means if you ask him to show his tongue, the tongue is deviated to the left side. Okay. The face is weak on the right side, sparing the forehead. This is another important sign. The face is weak on the right side. That means the same side as the paralysis, sparing the forehead. That means the forehead is normal. When you ask him to look up, he'll be not having any, he'll be having furrows on both the sides. There is, the forehead is spared of the paralysis. Blood pressure is 180, 100 millimeters of mercury. So he's hypertensive. So what could this be? Hemiplegia. Okay. Yeah, what could it be? So you can call this, if they ask you name, put the diagnosis, you say it is a upper motor neuron lesion. Upper motor neuron lesion. Where could the lesion be? It could be in the internal capsule because a large part of the body is involved. There a large number of fibers should be involved. So it could be the internal capsule. Complete paralysis of the right upper and lower limbs, loss of sensation on the same side. I'll be telling about all the. See, normally there are two reasons why this paralysis happens. One is there could be an obvious hemorrhage, but hemorrhage is very, very less when compared to ischemia. That means generally a clot from somewhere goes and blocks the artery. Okay. So it goes and blocks the lenticulostriate artery, which is the commonest area where it is blocked. So this will cause ischemia and the damage of the brain. So when the area around the ischemia is damaged, you will be having this type of paralysis. So he is brought within 1 hour, it has been told. So remember that 1 hour is very, very important. That is called the golden hour. It is the same for heart attack also. It is the same here also. If the person is brought within 1 hour, the area of damage, that means the ischemia will not be very, very high. That means the penumbra, the area around the ischemia, the damage will not be severe. But remember, whenever you want to refer a patient with cerebral stroke, you have to refer him to a hospital which has a MRI. This you remember. Don't send him to a general practitioner. Why? Because it is very important to understand whether it is an ischemia or a hemorrhage. Why is it so important? The treatment for ischemia is entirely different than for hemorrhage. Understood? So, generally 85% it is ischemia. Only 15% will be hemorrhage. But you have to be sure whether it is a hemorrhage or ischemia. So, that is why you have to take an MRI and then find out whether it's an ischemia. If it is a clot and he's not allergic to TPA, you can give a TPA. I told you, TPA is also used for heart attacks, myocardial infarction. Here also, to break the thrombus which is formed, you can use TPA. So how do you make out whether the patient is having this lesion when he is at home? So you have to tell these people about fast. That means you look at the face, there will be a deviation of the mouth to one side. You ask him to put both the arms forward like this. Only one arm will be up and the other arm will not be able to raise. Then ask him to tell his name. His speech will be a little blurred, slurred. Okay. So the speech will be slurred, and T is move him to the hospital within 1 hour. So FAST, you have to remember. F is look at the face. It will be, the angle of the mouth will be deviated to one side. Ask him to raise his arms. One arm will be normal, the other arm will not be able to raise fully. Then ask him to tell his name. There is a slurring of the speech. Move him to the hospital within 1 hour. What type of hospital? A hospital which has MRI. Okay. So, which part of the central nervous system is more likely damaged in this patient? Why is the paralysis of the side opposite to the lesion? Why is the upper part of the face spared despite facial weakness? Which vascular territory is most likely involved? Explain the physiological basis of tongue deviation to the left. These are some of the things that you have to remember. So, what are all the things that happened to this man? He's 58-year-old, so he's quite old. Sudden onset, so it happened suddenly, it didn't happen slowly. Right hemiplegia, right-sided sensory loss, tongue deviation to the left, right lower facial weakness, sparing the forehead, hypertension. So, which part of the central nervous system is most likely damaged? The left internal capsule, because it is the right side, it is the left internal capsule. Why is it the opposite side? Because the corticospinal tract will be crossing to the opposite side. So you can see here, that is the anterior limb, posterior limb, and the genu. You have the caudate nucleus, thalamus, lentiform nucleus, all around this one. Yeah. The region contains dense corticospinal and corticobulbar fibers. A small lesion can cause severe contralateral motor and sensory loss. I'll be showing it in the next picture. So you see here, if suppose the lesion is in the upper part where it is starting, because the fibers are far, far away, only a small part of the body will be involved. But as all the fibers come and converge near the internal capsule, suppose there is a lesion at the internal capsule, then a large part of the body will be involved. So that is why if a large part of the body is involved and he is having hemiplegia, generally it will be the internal capsule. Okay. So the corticospinal tract crosses at the medullary pyramids. Fibers from the left motor cortex control muscles of the right side of the body and vice versa. A lesion above the decussation produces contralateral hemiplegia. But suppose it is below that, after the decussation, there is an anterior corticospinal tract, lateral corticospinal tract, isn't it? So after that, if there is a lesion, it will be on the same side. Yeah. Why is the upper part of the face spared despite facial weakness? See, facial nerve is having two types of lesion. One is called a upper motor neuron facial nerve lesion and a lower motor neuron facial nerve lesion. And generally, the lower motor neuron lesion is more common in facial nerve. Suppose a person is traveling by bus and it is very cold and the cold air will be going into his ears. Then here, near the ear, there will be this what we call edema formation, and the lower motor neuron will be happening. That means the lower part of the face as well as the upper part of the face will be affected. But suppose he is having hemiplegia and there is a upper motor neuron lesion, then the upper part of the face will be spared. You can look at this picture. See, the upper part of the face will be having both upper motor as well as lower motor innervation. So you can see here, it is having innervations from both the sides. That is on the left and the right side. Sorry, left and the right side. So it is having a bilateral innervation. The face in the upper part, you can see here, it is having one innervation from the left side. It is having one innervation from the right side. Whereas the lower part of the face will be having innervation only from one side. That is why when there is an upper motor neuron lesion, the upper part of the face will be spared because it is having innervation from the opposite side also. Only the lower part of the face is affected. So the upper facial muscles receive bilateral corticobulbar innervation. That means from both the hemispheres. Therefore, if one hemisphere is damaged, the upper face still gets input from the opposite hemisphere, sparing the forehead. The lower face gets mainly contralateral corticobulbar influence. So it is affected. But remember, if the lesion is lower motor neuron lesion, both the upper as well as the lower part of the face are affected. Which vascular territory is most likely involved? The middle cerebral artery, because it is very, very thin, especially the lenticulostriate branches. So in this case, it is the left middle cerebral artery and the lenticulostriate branches. So you can see here, it is the lenticulostriate branch. That is the common thing which is affected. These are small penetrating arteries prone to hypertensive lacunar infarct. That means because they are very narrow, the infarct formation will be very easy here. Understood? The arteries can be blocked very easily. Explain the physiological basis of the tongue deviation to the left. This is also another thing. The tongue, I think all of you know, is supplied by the hypoglossal nerve. That is the cranial nerve 12, which controls the tongue muscles. What will happen? Corticobulbar fibers to the hypoglossal nucleus cross to the opposite side. Just like in the part of the body, here also it crosses to the opposite side. A lesion to the left hemisphere causes right-sided weakness of the tongue muscles. So the tongue muscles on the right side are weak. But here what is happening? The tongue is being deviated to the left side. Why? When protruded, when the person puts the tongue out, the stronger left side pushes the tongue towards the weaker right side. Because the left side is normal, it will be stronger than the right side of the tongue. So when he is asked to put out the tongue, the stronger side will be pushing the tongue to the weaker side. So he will be, the tongue deviation will be to the left side. So here it is the differences of the upper motor neuron lesion and the lower motor neuron lesion. This important question, you can go through it later on. Because of the shortage of time, I will not be talking much in detail. But remember, reflexes, when you are talking about reflexes, both the superficial and reflexes are lost in lower motor neuron lesion. Remember this. Reflexes, both the superficial as well as deep reflexes, are lost in lower motor neuron lesion. But in upper motor neuron lesion, the superficial reflexes are lost, but the deep reflexes are exaggerated. This you have to remember. The deep reflexes are exaggerated. I told you in Parkinson's disease also, I told you inhibitory and excitatory. So when the inhibitory is lost, the excitatory will be present. So deep tendon reflexes are exaggerated in the upper motor neuron lesion. Superficial reflexes are absent. In a lower motor neuron lesion, both the superficial as well as deep reflexes are absent. Then Babinski is positive. Many of you think because plantar response is present, you will be thinking that superficial reflex is present. See, remember, superficial reflex is present means the plantar response should not be extensor. Because the plantar response is extensor, because the Babinski is positive, that means the plantar response is there. The plantar response is positive only in upper motor neuron lesions. Sometimes physiologically also it is there. For example, suppose you are doing this on a small infant, okay, a newborn baby who's born, because there the myelination will not be proper. For them also the plantar becomes positive. That means Babinski sign is present. But otherwise, in a normal adult, there is a flexor which is present in lower motor neuron lesion. Upper motor will be positive, extensor. Clonus and all that. These are the main things that you have to remember about the reflexes and the so. So for you to, I have made a what you call a mnemonic for you to easily remember. What the heck? Please check for facts so that you don't miss out anything. Weakness, tone, hyperreflexia, plantar, clonus, fasciculation, facial. This you can go through it later on, but this is for easy remembrance. What the heck? Please check for facts. So we finished Parkinson's. We finished the upper motor neuron. So this is another thing which is very commonly asked. A 54-year-old man is brought to the emergency department after suddenly developing difficulty in walking and in balance. So remember, here also it is balance. His wife reports that he has been swaying to the right side while trying to walk. He's been swaying to the right side while trying to walk. He also complains of dizziness and nausea. On examination, the gait is wide based and unsteady with a tendency to fall to the right. So the gait is wide based and unsteady. Finger to nose testing shows pass pointing on the right side. That means I think you know how to do the finger to nose test. Shows pass pointing to the right side. Rapid alternating movements of the right hand are irregular and clumsy. So diadochokinesia, that is called diadoch. Muscle tone is normal. So here the tone is normal in this patient. Muscle strength is preserved. So muscle strength is preserved means it is not a upper motor neuron lesion. Muscle tone is also normal, whereas in upper motor neuron lesion we will be having spasticity. Cranial nerves are intact. All the cranial nerves are normal. An MRI of the brain reveals a lesion in the right cerebellar hemisphere. So remember, whenever the cerebellum is affected, there will be a problem with the balance. Understood? And there will be a problem with the coordination because these two are the main functions of the cerebellum. So the coordination between the muscles is lost. So that's why you will be having the finger to nose test, rapid alternating movement and all that will become clumsy. So what is the tremor which is present here? I told you. What is the type of tremor here? Intentional tremor. Yes. Intentional tremor means the patient is having a tremor only when he is about to pick up something or when he is doing some work. So that is called intentional tremor. Whereas in a Parkinson's disease, it is called a resting tremor. Even at rest, it is there. Which functions of the cerebellum are primarily affected in this patient? What is the physiological basis of dysdiadochokinesia? That is inability to perform rapid alternating movements. Why does the lesion cause symptoms on the same side, ipsilateral as the lesion? This you have to remember. Here, the lesion is on the same side as the effect. Whereas in the upper motor neuron lesion, what did you have? The lesion was present on the opposite side of the effect. That means if the right side is affected, the lesion would be on the left side in upper motor neuron. But here, if the right side is affected, the right side is affected. The right side movements are affected. That is because there is a double crossing. I think you know that. Which specific cerebellar subdivision? See, it has three things, isn't it? Vestibulocerebellum, spinocerebellum, cerebrocerebellum is most likely affected in this case. I'll be telling you how you can make that out also. How would this presentation differ from a basal ganglia lesion? See, the common confusion to the student is also between Parkinson's and cerebellar. Because there also balance is lost, here also balance is lost. But remember, there will be rigidity. Here there will not be any rigidity. Okay. Yeah. Which functions of the cerebellum are primarily affected in this patient? Balance. So this person will be having ataxia. What is ataxia? You ask him to close his eyes and keep his legs close together. He will be falling down. That is called sensory ataxia. That means if he opens his eyes and he's not having ataxia, but is having ataxia only when he closes his eyes, that is called sensory ataxia. But if he is not able to maintain his balance, even when his eyes are open, that is called motor ataxia. Motor ataxia. You understood? When he is able to maintain his balance with his eyes open, that means he's keeping his legs together, he keeps his eyes open, and he's asked to stand, he'll be able to stand. So that is called sensory ataxia because when he closes his eyes, he will not be able to see the external environment and he will not be having any feeling, sensations from his feet. because it is sensory ataxia. So that type of person will fall down only when he closes his eyes. Whereas if he is not able to maintain the balance even with his eyes open, that is called motor ataxia. So here he will be having motor ataxia. The cerebellum integrates sensory input with motor commands to produce smooth, coordinated movements. In this patient, the main deficits are ataxia, dysmetria. Dysmetria means pass pointing. That means the velocity of the movement cannot be controlled by this because the cerebellum is affected. So, dysmetria. Suppose I want to drink a cup of coffee. I know with which pressure I have to bring it till the mouth, isn't it? I know when to stop. But here, there is no coordination of movement and there is no coordination on the velocity of the movement also. So, the patient will not be able to bring it properly. So, that is called pass pointing. When he is asked to touch the finger, the touch his nose with the finger, it will be pass pointing. So, that is called dysmetria. Dysdiadochokinesia, you ask him to do alternate movements by asking him to open his palm and do alternate movements. He will not be able to do it. These are classic cerebellar signs. Understood? Ataxia, dysmetria, dysdiadochokinesia. If these three are present, it is a cerebellar lesion. In addition to that, I told you he'll be having intentional tremors. Intentional tremors are also characteristic of cerebellar lesion. What is the physiological basis of dysdiadochokinesia? So, what is dysdiadochokinesia? Inability to perform rapid alternating movements anywhere in the body. It occurs because the cerebellum normally helps coordinate the timing and switching of agonist and antagonistic muscle activity. So, what does the cerebellum do whenever you are walking or whenever you are moving? It will be helping to coordinate the timing and switching of agonist and antagonist. That means when the agonist muscle should work, when the antagonistic muscle should work, this is all timed by the cerebellum. When there is a lesion in the cerebellum, this timing is lost. That's why the pass pointing and all that will be happening. With a lesion, the reciprocal inhibition between muscle groups is poorly controlled. Movements become irregular and clumsy. Whereas in what you call that basal ganglia, the initiation of movement itself was difficult because the blueprint of the movement is formed in the basal ganglia. So the initiation of movement was difficult there. Here it is not the initiation. The coordination between the muscles is lost here. Why does the lesion cause symptoms on the same side as the lesion? See, I told you upper motor neuron lesion, it is on the opposite side if it is at the level of the internal capsule because the crossing of the corticospinal tract. Here it's on the same side. See, same side means it is called ipsilateral. Opposite side means it is called contralateral. These two words you have to remember. Ipsilateral means on the same side. Contralateral means on the opposite side. Okay? So the explanation is motor cortex, contralateral corticospinal tract goes to the spinal cord. So that's why if on the left side of the motor cortex you have the corticospinal tract, it goes to the right side of the spinal cord. So it goes to the opposite side. The crossing over happens at the medulla. Cerebellum projects to the motor cortex via the contralateral thalamus. But since the motor cortex itself controls the contralateral body, the double crossing results in ipsilateral clinical changes. So remember, there is a double crossing. That is why what goes to the left side again comes back to the right side. So here the lesion is ipsilateral because of the double crossing. Whereas it is contralateral in the upper motor neuron lesion because the crossing is only to one side. Which specific cerebellar subdivision is most likely affected in this case? Cerebrocerebellum, lateral hemisphere, because planning and coordination of skilled voluntary movements happens here. Supporting evidence is patient has limb coordination, incoordination, that means pass pointing, dysdiadochokinesia, everything, rather than just truncal ataxia or eye movement disturbances. Only if he's having truncal ataxia, or suppose he's having some nystagmus or some abnormal eye movement disturbances, then you can think about the vestibulocerebellum. But here it is planning and coordination of skilled voluntary movements is lost. That's why it is the cerebrocerebellum. So, but if truncal ataxia is there, it is spinocerebellum. Eye movements are disturbed, then it is vestibulocerebellum. So here it is cerebrocerebellum. If vestibulocerebellum was affected, more vertigo, nystagmus, truncal ataxia would be present. How would this presentation differ from a basal ganglia lesion? Cerebellar lesion, ataxia, intention tremor. This is what I was telling you. Intention tremor means the tremor is there only when you're doing some work. Otherwise, it is not there. Dysmetria. Dysmetria is lack of coordination. Pass pointing and all that will be there. Dysdiadochokinesia. He will not be able to do alternate movements. Wide gazed gait. This is also called drunken gait. Understood? If a person is fully drunk, how does it move? He moves with a wide-based gait. So this is called a drunken gait or a cerebellar gait. What was the gait in person with Parkinson's called? Person with Parkinson's. Shuffling gait or festinant gait. That was shuffling gait or festinant gait. That means he was trying to catch his center of gravity. Otherwise, he will fall down. So he puts his leg in front. Here, movements are clumsy and poorly coordinated. Whereas basal ganglia, abnormalities of movement initiation and muscle tone. See here, the muscle tone is increased and that is called rigidity. What are the two types of rigidity in basal ganglia? Cogwheel rigidity and lead pipe rigidity. Whereas in upper motor neuron lesion, it is called spasticity. Upper motor neuron lesion, it is called spasticity. Then in the basal ganglia lesion, resting tremor, rigidity, bradykinesia, or involuntary movements, chorea, ethitosis. See, chorea and ethitosis, these are seen when the caudate nucleus or the putamen are involved. For you to easily remember, caudate nucleus starts with C. So, if the caudate nucleus is affected, chorea is seen. Okay. Caudate nucleus is affected, chorea is seen. Putamen is affected, ethitosis is seen. Movements are slow or excessive. They are not only simply uncoordinated. Understood? That means the movement, he may be, there is a movement called retropulsion in a Parkinson's disease. Retropulsion means suppose the person is standing, you push him from behind. He will not be able to stop. He goes on running forward. Understood? You push him from behind, he goes on running forward because he does not know how to stop. So the movements are slow or excessive, not simply uncoordinated. So this is showing that it is a cerebellar lesion. Okay, last, I'll be finishing this off in 5 minutes. Remember, this is not central nervous system, but this is also given many times. Understood? A 28-year-old woman presents with complaints of progressive weakness that worsens throughout the day. This is an important line. Progressive weakness that worsens throughout the day. That means from morning to evening, the weakness will be increasing. Understood? It is not that every day morning also she is as weak as she is in the evening. In the morning, it will not be very weak. By the time she becomes, when it becomes evening, she becomes very, very weak. She reports that in the morning, she feels relatively strong, but by the evening, she struggles to chew food, keep her eyelids open, and climb stairs. On examination, she has bilateral ptosis that becomes more pronounced after sustained upward gaze. Ptosis means drooping of the eyelid. Bilateral ptosis. Remember, in this condition, it is bilateral ptosis. That means both the upper lids are falling down. If it is unilateral, you have to think about lesion of the facial nerve. Okay. Muscle strength in the proximal limb muscles decrease after repetitive testing, but improves after a short period of rest. So remember here, whenever the muscles are at rest, are given rest, then the movements become strong. Whenever a muscle is being used, it becomes weak. For example, when she starts chewing, in the initial stages, it is easy. After that, it becomes more difficult. sensory and reflex examinations are normal. Okay. A test with edrophonium. This you have to remember, edrophonium. They have been asking many number of times, and most of the time you don't know what is edrophonium. Understood? Edrophonium is a short-acting acetylcholinesterase inhibitor. Temporarily improves her symptoms. Further laboratory work shows the presence of antibodies against nicotinic acetylcholine receptors at the neuromuscular junction. Okay. So this is a autoimmune disease. What is the underlying pathophysiology? Why do symptoms worsen after repeated muscle activity? How does edrophonium improve muscle strength in the patient? Which muscle groups are most commonly affected? What is the association between myasthenia gravis and thymus, thymic abnormalities? Okay. So you see here, I think all of you know, in a neuromuscular junction, whenever the action potential comes, the calcium channels opens in the presynaptic neuron, and the calcium enters, pushes the acetylcholine, what you call that, receptors, acetylcholine vesicles outside, and they go out and sit in the receptors, and the action potential is continued. Okay, that happens normally. But suppose the receptors are having something else, and this acetylcholine is not able to go and sit on the receptors, then the muscle action potential will not be formed. Or you can see deep depressions, isn't it? Where you have acetylcholine receptors. If those depressions become more flat, the area for the acetylcholine to act will become less. So this is also a problem. Both the things happen in myasthenia gravis. It is an autoimmune disorder in which antibodies are produced against the nicotinic acetylcholine receptors at the neuromuscular junction. These antibodies block, alter, or destroy the receptors. So sometimes they destroy, sometimes they change, sometimes they completely block, reducing the efficiency of the neuromuscular junction. The end plate potential fails to reach the threshold, leading to muscle weakness. So here you can see on the right side you have myasthenia gravis. So you can see the acetylcholine receptor antibody is blocking the acetylcholine receptor. So it is not allowing the acetylcholine to work on the receptor. So the end plate potential is not reaching the threshold. Understood? All small and plate potentials are there. Whereas here you can see the acetylcholine is coming, sitting on the receptors, and the action potential is formed. End plate potential is becoming big, and the action potential is formed. With repeated activity, acetylcholine release decreases and fewer receptors are available because they are blocked or destroyed. This leads to fatigability. After rest, acetylcholine stores are replenished, allowing temporary improvement. This is called fatigable weakness, a hallmark of myasthenia gravis. So remember that whenever acetylcholine is used up, it will be replenished. See, what is the function of acetylcholine? Whenever it is coming to the synapse, it works only for a few milliseconds. After that, it is either washed off, or there is a reuptake into the neuron, or some of it will be, most of it is removed by acetylcholinesterase. So these three things happen. That means acetylcholinesterase will destroy the acetylcholine. Second thing is it is washed away from that synapse. Third thing is there is a reuptake. So how can we treat this condition? How can we allow the small amount of acetylcholine to stay there for a long time? By destroying the acetylcholinesterase. Understood? What does acetylcholinesterase do? That is going to break down the acetylcholine. So it will not be allowing the acetylcholine to function for a long time. So if acetylcholinesterase is removed, what will happen, or is not allowed to function? What will happen? This acetylcholine will be able to stay there for a longer time. So that is the treatment for this condition. How does edrophonium improve muscle strength in the patient? Edrophonium is a short-acting acetylcholinesterase inhibitor. So the test also uses edrophonium, which is the short-acting acetylcholinesterase inhibitor. It prevents the breakdown of acetylcholine in the synaptic cleft, increasing its availability. With more acetylcholine present, there is a higher chance of activating the reduced number of receptors, improving muscle contraction temporarily. That's why whenever you see that if the hydrophonium is injected, the patient becomes normal for a few minutes. So this is a clear-cut test to make out whether it is myasthenia gravis or not. Which muscle groups are most commonly affected in myasthenia gravis? Mostly it is extraocular. I told you ptosis is there, diplopia. That means the person will be seeing two things. But most common thing which is seen is ptosis. And remember here the ptosis is bilateral. Both the eyelids will be falling down. Bulbar muscles, difficulty in swallowing, chewing, and speaking. Then proximal lymph muscles, difficulty in climbing stairs, lifting arms. Respiratory muscles. So respiratory muscles is the respiratory depression is the thing in which most of these people die. Understood? Respiratory muscles are affected and it results in a myasthenic crisis. And generally the patient will die because of respiratory paralysis. Small, frequently used muscles like ocular muscles are especially vulnerable. That's why initially when you make out, patient will be complaining of weakness, but he'll be coming with ptosis. And this is more common in females. So generally in the case also, they'll be writing she. Okay? So many patients have thymic hyperplasia or thymomas. That is why the thymus is removed. Understood? The thymus plays a role in T cell maturation and autoimmunity. Abnormal thymic tissues may drive production of anti-acetylcholine receptor antibodies. That's why thymectomy can improve symptoms in some patients. What it means is thymus is the place where the T cells mature. Understood? That I think you all know the lymphocytes are B cell and T cell. So the T cells mature and these acetylcholine antibodies are because they have thymic and drive production of anti-acetylcholine receptor antibodies. So that is why if you remove the thymus, these antibodies will be less. That's why the thymus is removed. See, the treatment here is neostigmine or physostigmine. Remember, you have to write neostigmine and physostigmine. Don't write corticosteroids as the basic treatment. Understood? And don't write removal of antibodies as the treatment. The basic treatment is physostigmine and neostigmine. Both are anticholinesterase inhibitors. They will inhibit the action of cholinesterase. Okay. So these are the common conditions which are given for you from CNS. So paper 2, I think we have covered a lot. In paper 1, you have hematology, then respiratory system, especially hypoxia cases they give, hypoxia. Then in what you call uh, gas, peptic ulcer is a very common thing which is given in gastrointestinal as well as constipation. And one of the common things which is given is jaundice. Understood? So these are the common cases. If I have time, I will try to talk about hematology because iron deficiency anemia, then bleeding disorders, clotting disorders, then blood transfusion reactions. All these are clinical cases for you. If I have time, I'll be telling that briefly. But thank you very much for participating in this thing. You will be given the feedback. Please write the feedback. You don't have to write your name. Please write the feedback and give it to me so that we can improve or we can go on continuing these classes for a longer time because I am very happy that the students up till final year are finding it useful. Hmm? And I'm getting very good feedback from the senior batches that it has been useful. But remember, I have put it more for the first years. That means they have to understand the concept. Same thing is the seniors should also understand the concepts. Then they have to build up upon the concept. They have to build on the concepts. Then it becomes easy for them to remember things, to remember the treatment, to recognize the sign symptoms, and to understand what is causing the sign and symptom. So thank you very much, National Medicos Organization, for giving me this opportunity of meeting such a good number of students. Tomorrow and after tomorrow, you'll be having arterial blood gas analysis, part 1 and part 2, by Dr. Vijayalakshmi, who is the professor and head of the Department of Biochemistry here. So this is also important. Later on, I thought that I'll also be taking about arrhythmias, cardiac arrhythmias, tachyarrhythmias and their treatment, bradyarrhythmias and their treatment, cardiac arrest and their treatment. All these are important questions for you. So I think I'll be taking them later on. I have to design those things first. So thank you very much. Thank you very much, Ajay, for asking me to take these classes and for making all these arrangements wonderfully. And I thank Dr. Sagar also for giving insight to the activities of NMO. I think it is really very great that you are doing all such things, and to make the students also have nationalistic attitude so that they will work for the country. Thank you very much.
Thank you very much, sir, for your valuable and insightful session. On behalf of JSL Medical College and National Medicos Organization, I sincerely thank our respected speakers, distinguished guests, and all the participants who joined us today and over the last 4 days. This 4-day clinical cases series has been an enriching journey covering diverse systems, guided by eminent faculty, and supported by the active participation of students and doctors across institutions. A special note of gratitude to Dr. Perninka Srinivasarao sir, Professor, Department of Physiology, JSR Medical College, Rajahmundry, for his continued guidance, and to Dr. Sagar sir for his inspiring with the vision and values of NMO. With this, we formally conclude the series. Thank you all once again for your time, attention, and encouragement. We look forward to meeting you in the future, academic and professional. And we had exciting news. We are extending this session for 17th and 18th of this month. We are having a session on arterial blood gas analysis, ABG, part 1 and part 2, by UB Vijayalakshmi, Professor and Head, Department of Biochemistry, JSR Medical College and General Hospital. I conclude this session by thank
Om Shanti Shanti Shanti.
Thank you, sir. I hope you will all the students will join for day 5 and day 6, arterial blood gas analysis, part 1 and part 2. Thank you, sir.
Thank you. Thank you.
And I also thank Team Clirnet for their extended support. Mrs. Ritu, coordinator for this session, and Mrs. Rimpa, moderator of this session. Thank you so much, sir.
Yes, thank you so much, everyone,
Sir, can
for
we end
joining
up the
this
session?
session.
Okay. Okay. We'll end up.
Yeah,
Thank
thank
you,
you so
Rimpa.
much, everyone, for joining this
Thank
session.
you, sir.
Yes, Clirnet is really glad to have all these brilliant people together. So, with all your permission, shall I close the session for today?
Yes, please.
Yes,
Yes,
Rimpa, you can.
yeah.
Thank you,
Thank you,
Rimpa, for
sir.
your extended support.
Yes, sir. Bye, sir.
Thank you.